I wanted to thank the organizing committee and Deanna, of course, for inviting me to speak. It's always a pleasure. I did this a few years ago. Before I start, I just wanted to say the most important people today are the patients. Physicians are not as important because the journey is really with the patient. That's the most important thing. People like Deanna who are advocates, and it's so nice to see several of my patients here today to support this important event. So I just wanted to start off by saying that. And there will be some overlap with Dr. Stan Van Oom's presentation, but redundancy is always good because at this time with all the coffee and high glycemic index foods with a diabetogenic environment, we have to realize we're all probably going to fall asleep. And if you find that I might throw things at your desk to wake you up, so please bear with that. So these are my disclosures. I just wanted to be transparent with that. I do receive some fees. So I have 3 objectives. When Deanna asked me to speak, first of all, I didn't realize I'd have to speak after Dr. Izzat, who was my mentor and my supervisor. So my heart's already beating really fast like a periganglioma. He's been my mentor for a long time, and a lot of what I've learned today is from him. So if I say anything wrong, it's his fault. Just wanted to let him know. I'm not sure if Shireen's still on the call right now watching. What is acromegaly, briefly, because I think we all know about this. This is a very high-level crowd. How is it different in the elderly? And lastly, what is the treatment in the elderly? So if you don't remember anything today, this is the most important slide. Okay? This is the most important slide. So I'll let you take a few seconds to read it because I'm not going to go through every single sentence. But this is something that we should all take in very seriously because you're never too old, right? And it's just we're less younger, but not too old. Less younger. And I think my slides are going to be shared, so you can read this over later. Yeah. So acromegaly, interesting. Acros comes from extreme, and megalos means large, and that's where the term acromegaly comes from. So it's, like Dr. Izzat said, this is more than just everything getting big, your face, your hands, your feet. But that's where it comes from. And we all know that it's actually, at the end of the day, it's because you have too much growth hormone, which is a normal hormone. We need this hormone. But when you have too much, you're going to run into troubles. And interestingly, as we get less younger, this hormone actually does get lower. So it might be protective. There's a reason, whatever you believe in, that things happen in life that may be protective. But unfortunately, because of a disease state, because of a condition, if they rise, you get the condition called acromegaly after the bones close and before gigantism, as was mentioned earlier. Most of these cases are due to the typical, that was mentioned earlier, due to a pituitary tumor. But a very few rare cases, I only have one case of ectopic, is due to some other rare cause, such as ectopic GH, RH, or etc. And most of the tumors, and Dr. Cusimano can comment on this too, are big when they're diagnosed. It's really nice to find a nice tumor which sits in the sella, which is the Turkish saddle, where it's small, there's no cavernous sinus invasion, and most of those patients do really, really well. It's amazing. And it's got to be, you got to pick a Cusimano. It can't be someone who's doing a spine surgery or a non-cellular surgery or skull-based surgery. You want to find a Dr. Reddy that we have in Hamilton, or Dr. Cusimano, or Dr. Feeling, someone who's going to do a lot of these things that are active and very, very good at doing pituitary surgery. So you don't need a neurosurgeon. You need a pituitary experienced surgeon who's doing at least a couple a week, I would say, roughly. How common is it? It's rare, but it's not rare for you. Who's the most important people? The patients. So it is rare, but we need more detection methods. We need more awareness, because I've seen a lot of people at Tim Hortons, Starbucks, McDonald's. I go to McDonald's sometimes, but I go, and I've seen people who I think I need an IGF-1 level, and it's always been, what do I do? Because I'm a physician, but what's the ethics around that? So I actually have gone and spoken to them, and I introduced myself as, I'm a doctor, and it's done very quietly, and I say, maybe you should see your doctor and get this test done, because in Canada you can't be referred directly. You have to have a referral from someone else. So it's rare, but it's not rare for us. And we do know that it is getting more picked up in people who are less younger. And that's the whole talk of today that Deanna asked me to speak about. And probably because people are living longer and we have better tests and people are more aware of this condition, hopefully, we're finding this. The important thing is that we're really missing the boat. The journey is very long. People see cardiologists, rheumatologists, psychiatrists, because quality of life is affected. And finally, they might see an astute internist or a neurosurgeon or an endocrinologist, and they go, this is the diagnosis. So the journey is very long. People can go 5 to 10 years without making the diagnosis, and I've heard that quite a bit today. So Dr. Van Oom's going to go into this more a lot, but again, everything grows bigger. Your organs get bigger. It has complications, right? Sweating, as mentioned earlier on, carpal tunnel syndrome, colonic polyps, sleep apnea, high blood pressure, diabetes, et cetera, et cetera. The point of this slide is there's a lot of overlapping symptoms and signs, in people who are getting less younger, and acromegaly. Diabetes is very common. It's in our water. Look at the food back there, right? Hypertension, very, very common. So all these, and there's a lot of delay. So people think, oh, maybe this is just garden variety, age-related diabetes, but we got to really look at our patients and listen to them and look at old pictures. I always tell the residents, did you ask the patient about old pictures? And that's where the surprise comes in. A lot of endocrine diseases, Cushing's syndrome, acromegaly, old pictures will tell you a lot, right? They're licensed, and everyone's got a smartphone now. People have 4,000 pictures, right? You can go back. It takes a while to scroll down, but you'll find old pictures, so that's really important. And again, this is the pictures really help minimize, I think, the diagnosis delay. And it's not, you can't blame anyone. We're learning, right? And the thing is that when they see their family doctor or their nurse practitioner in primary care, they're going to miss the diagnosis because they see them quite often, where if I see them at once in time, it's probably going to be easier for the specialist to pick this up. So it's not, we shouldn't be blaming our colleagues, such as the primary care physicians, because they're just seeing them very slowly, because this disease usually is very, very, very gradual. It's not like Cushing's syndrome, which is much more subacute, or actually could be acute also. Just want to show some pictures showing this is over many, many years. This doesn't happen over a few months, so it's a very insidious, slowly progressive condition. Our goal is to break this journey and find it earlier and detect it earlier with earlier screening and so on. So as I mentioned, there's a lot of overlap. As you get less younger, if you have acromegaly, a lot of these things happen in both populations. Diabetes, sleep apnea, abnormal cholesterol medications, high blood pressure, heart disease, arrhythmias, colonic polyps. There's a lot of overlap. So this makes it somewhat challenging also. So if you see someone with lots of things going on like this, think about acromegaly, right? Especially if there's a pattern of a constellation of symptoms, signs, and complications, we must think about growth hormone excess or acromegaly. The worst arthritis I've seen is in patients with acromegaly. It can be very debilitating. And my heart reaches out to these patients who get bad arthritis, secondary or non-typical arthritis, and often it happens in the hips, and if it's in the knees, it's very, very bad because of the delay of the diagnosis. Fortunately, if it's caught early, it may be reversible, but a lot of these patients need total hip replacements and other orthopedic interventions. So we have to find these people earlier to help our patients do the best we can. Something else that's underappreciated is the neuropsychiatric manifestations. We always think maybe it's just depression, maybe there's something going on at home, but growth hormone does something to your cortex, to your hippocampus, which are areas in the brain, to many, many parts of the brain that can cause subtle features or even overt features of psychosocial type issues, which is very, very debilitating to the patient. So we must take this seriously. When patients tell us that they're not feeling well, they're just not the same, especially if there's associated lots of other things going on, the sleep apnea, diabetes, etc. So we have to listen to our patients, and it can have effects on their quality of life. I've seen issues in the family because of this, because they've been misdiagnosed or not diagnosed. So quality of life, neuropsychological issues are not uncommon with acromegaly, and it can affect their mobility, and it's a vicious cycle. We have to break that cycle if we diagnose them early. So we've heard this a few times. If you do have acromegaly, which is untreated, and there's a delay, there is a risk of increased death and morbidities compared to the general population. There's a higher risk, mainly, it's the heart. So if you think of 3 organs that are really affected in terms of lifespan, it's the heart, because of accelerated hardening of the arteries, known as atherosclerosis, sleep apnea, which can be quite debilitating and a marker of morbidity. And it's controversial now whether acromegaly does cause an increased risk of cancer. The jury's still out, but there is a higher risk of precancerous growth, thyroid nodules, colon tumors like colonic polyps, etc. But again, there's a family that has associated conditions that happens with acromegaly, and the more you have, the higher risk of mortality and morbidity, especially with the high blood pressure and the diabetes, etc. And they can also have, of course, the visual field deficits, which we talked about. Interestingly, I think Dr. Kusumana might have mentioned it, but unlike non-functioning pituitary tumors, these tumors grow downward usually, not always. So the visual field effects, luckily, are not as bad usually, but not always. Nothing plays by the textbook these days in medicine, right? We have to remember that. And the good news is, and I'll show you, is that if we can control their growth hormone levels and their IGF-1 levels, the mortality is significantly reduced. So there is always good news. I always like to give good news. So when you leave today, there is good news. 2 things. You're never old, and we can help our patients with acromegaly. So again, as I mentioned, if you compare patients with acromegaly versus without acromegaly in large trials, if you have the same conditions, you're probably not going to do as well if you have acromegaly. But the good news is we can break the cycle by effective therapy, surgical being number one, and we also have good medical therapies, and sometimes you need radiation therapy. So should we be screening everyone? Of course not, right? We got to look at our patients because we don't want to do all these tests. We're already in bankruptcy in Canada with our healthcare, right? So we have to pick our patients carefully who we're going to screen. So someone who has typical features, enlargement of certain hands, feet, nose, tongue, etc. Think about investigating their IGF-1 levels, easy to do. Several associated morbidities, diabetes, sleep apnea, hypertension, etc. Think about it there. And if there's a tumor that's seen on the MRI, and we talked about the MRI, which is really important, the type of MRI, think about investigating there. Now, there's controversy whether small tumors should be investigated with an IGF-1 level. I think we have to look at our patient and decide if there's enough reason to do it. In big tumors, I'm doing it, but again, there's not much evidence. The Endocrine Society, it's a grade D recommendation to screen everyone. I'm not sure if I agree with that because the States is a little bit different than us. Their funding system is quite different from Canada. In Canada, we're not as rich, so every time you order an IGF-1 level, it comes out of your line 150 T4 income at the end of the year when you file your tax return. So nothing's free, right? We think it's free, but nothing's free. We still have to pay for it indirectly. Who makes the diagnosis? It depends. It depends. It could be internal medicine, it could be neurosurgery, endocrinology. I think dentists might be missing a lot of these diagnoses because the training is not there. It's not their fault. It's just that we're not training a lot of our other healthcare colleagues about what acromegaly is. If I go back to medical school, I think I must have had a half an hour teaching session on acromegaly. Half an hour. That's it, right? So we don't get much training unless you get interested, like us who are endocrinologists or people that are here today. So rheumatologists, I think maybe missing it in someone with severe arthritis. So I think there's a lot of room here for awareness and screening and knowledge translation. So that's where we are here today. We have to educate our partners that are working in this area because if we can break that journey early, I think we're going to really do service to our patients. Diagnosis, I'm not going to spend, the best test is the IGF-1 level. It's the equivalent of the hemoglobin A1C in diabetes. It's a few month marker of growth hormone excess, and it's the best test. Sometimes you need a test where you actually drink glucose and you do growth hormone levels every few minutes after, especially if the IGF-1 level is borderline or you're not sure. It's the same test we do in pregnancy where you measure glucose. Here you do glucose and growth hormone levels. You don't always need it, but sometimes you do. Interestingly, IGF-1 level is affected by many, many things. There are certain conditions that can actually falsely lower IGF-1 level. Poorly controlled diabetes, liver disease, kidney disease, malnutrition, if someone's very sick. So you might see someone with overt acromegaly looking at them, and your IGF-1 level may be low or normal. If they have any of these conditions, to name a few, then you might need to go on to do another history and physical and maybe do that 75 oral glucose tolerance test. So be aware that tests are not perfect. We have to always go back to the books and see if there's any other nuances in this. And this is very high level type of stuff that we have to think. For the most part, it's not an issue, but there are select cases where you have to take this into account where the IGF-1 level may be normal, but they still may have florid acromegaly. And it might be typical acromegaly, but just the tests are being affected by certain medical conditions the patient has. MRI is again, a very important test because more than 95% of cases of acromegaly are due to a pituitary adenoma, usually big, but some of them can be small, less than a centimeter arbitrarily. And in the elderly, looking at the series that I reviewed on the literature, in elderly, actually, they're often smaller based on the literature, but again, institutions will vary what they're seeing, but at least in the literature, that's what I saw. And it's important to do an MRI of the pituitary and not the brain. And if you're really worried, at least for the first time, usually the first time we order an MRI, especially for Cushing's, you want a very, very dedicated, dynamic, fine-cut MRI, and we use something called a Tesla 3 MRI, which is a more, I don't want to get into the details, but it has a higher pickup yield of smaller tumors. Especially Cushing's, the tumors are much smaller, unlike acromegaly, where they're often bigger. We have two Tesla 3s in Hamilton. Most of them are Tesla 1.5, which are not as accurate for small tumors. And we want to use contrast the first time around, also contrast called gadolinium. So it's got to be done properly. So we made the diagnosis. What do we want to do in the less younger? Very similar to what we want to do in patients who are much, much younger, okay? We want to make them feel better. We want to control the biochemistry, the growth hormone and IGF-1 levels. We want to make sure the tumor doesn't grow or, in fact, even get smaller. We want them their pituitary function, all the other hormones, the sex hormones, the thyroid hormones, the water hormones to be maintain their function, and we want to prevent recurrence. So we want to aim for hopefully cure or maximal debulk, getting rid of most of the tumor so we can use the minimal amount of medication needed so we can cost save and also prevent the side effects with some of these medications. And we want to make people live not only longer, but a healthy longer, right? It's all about healthy longer, not just living longer. And don't forget about the cousins they carry, the diabetes, the high blood pressure, the lipids, the sleep apnea, the polyps. We want to treat everything. So this has to be a holistic approach. We shouldn't be just focused on the big hands and the big feet. That's a part of it, but it's the whole patient that we want to treat. So, and we know the good news is that if we do this, by controlling acromegaly, whatever way we do it, we're going to decrease the risk of morbidities and death. This is what the slide summarizes, okay? It's all good news. We can decrease the risk of fractures and all these things that we talked about earlier on. So management, the first line therapy, absolutely. We need our surgical colleagues. We did not a neurosurgeon, but we did an experienced, quote unquote, an experienced pituitary surgeon who's doing lots of these, not just one a year, lots of them. And we have two, fortunately, at our site in Hamilton, and Toronto has a few more because it's a bigger city. And then, there's also medical therapies, which I'll talk about briefly. There is a role for first-line medical therapy, but for the most part, first-line therapy is surgery in the less younger and the much younger. And there's a small role for radiation therapy. And like I said, this is not something you do in silo. We have to work as a team. That's the other thing I want to mention. Acromegaly is not a one-person show. It's a team. It's endocrinology, pathology, radiology, neurosurgery, psychiatry, psychology, cardiology, rheumatology. It's a team, depending on what complications they're having, so we can't do this alone. We need a multidisciplinary focus. So most centers, academic centers, have a pituitary clinic where you work together as a team. One person doesn't make the decision because that's not going to serve the patient the best. We need a multidisciplinary team to do this together. Surgery is first line, and based on the literature, the articles that, if you review them, in the hands of a good surgeon, we're seeing similar success rates in the less younger and the very younger patients. Okay? And it's done transsphenoidally. So it's rare that someone needs to go do it with a craniotomy, where they have to cut a hole in actually the skull. So the fortunate thing is transsphenoidal is much safer, and it's done really well in the hands of a good surgeon, especially if there's good care on the operation time to make sure their heart and lungs are okay, etc. And again, if it's a small tumor in the hands of an experienced surgeon, they're going to do much better. So I know I keep on mentioning a surgeon, but a surgeon is very important here. We really rely on our surgeons to really help us out here. And some people do need medical therapy afterwards. So again, we have lots of therapies available. We have three broad categories of medication therapy. We have the somatostatin analogs, such as injections, the octreotide analogs. We also have cabergoline or Dostinex, which has an effect on dopamine. And then we have one of the newer, it's been around for a long time, but it's the newest therapy, pegvisomant, which actually blocks the growth hormone effects. So we have to, it depends on the patient, how we're going to choose these therapies, and that's beyond the scope of today's interaction. But the therapies overall, what I wanted to point out here, are very similar in someone who's very young versus someone who's less younger. So there's not much of a difference. So the point I'm trying to make is we shouldn't be looking at age as a cutoff for how we're going to treat our patients. Unless there's significant heart and lung problems where they're frail and they don't want surgery, we have to respect the patient's decision. As you can see, I keep on alluding that the patients are the most important part of this journey. So medical therapy, when would you say no surgery? If it's a huge tumor and it's unlikely you're going to get any significant resection, that's not very common. And you have to ensure that there's no vision compromise also, because that can be very, very, if that's an issue, they probably need some debulking, usually, not always. And if there's lots of invasion into the cavernous sinus where you can't get any tumor out at all, and that's going to be a surgical, neuroradiological decision. Of course, if they have significant heart-lung issues, and they're very frail and the limited life expectancy, you're going to offer medical therapy, of course. That's important. And the patient may say, I don't want anyone to go into me, and you have to respect them. You give them the informed consent and the risks and benefits, but the patients make the final decision. It's their decision, along with the endocrinologist. There's a small role for a radiotherapy, and this is more commonly in someone who has had surgery usually, and the surgeon can't go back in because it's not safe or they're not going to get much out. They've had intolerances to medical therapy. The medical therapy is not working, and then you want to bridge while the medical therapy is kicking in. The radiotherapy might kick in to help it stabilize in terms of the tumor and lower the growth hormone level. So this is going to be important to involve your radiation oncology colleagues also to get an opinion. So how do you monitor it? So you made the diagnosis, you started treating them, they're doing well. How do you monitor them? Well, first you want to talk to your patients. Virtual endocrinology is important, but I think we still need to see our patients in person. I like to see my patients with acromegaly in person. I don't like these virtual things because I need to examine them. I need the bedside manner, and we need to see them physically. Check their blood pressure. How are they doing? What's their quality of life? And depending on how stable they are, this is going to be every 3 to 12 months' time. You always want to assess their diabetes and their heart status by blood test and clinically. Again, same time. One of the paramount things is the blood test. So the IGF-1 level, history and physical are very important, but the IGF-1 level is going to prove biochemically if they're in control or not, taking into the caveats of the things that can lower falsely the IGF-1 levels. MRI, of course, may be done periodically, especially depending on the blood test. And sometimes patients also need formal visual fields where you go to a neuro-ophthalmologist and they take that red pin and tell you where it's going. And that's sometimes important to see if they can drive, and also an indication for earlier surgery or if they need radiotherapy, etc. And colonoscopy as per guidelines based on the Health Canada recommendations. And a lot of people also need a sleep study if there's a concern of sleep apnea. Not everyone. If someone tells you they feel great in the morning, they have a refreshed sleep, then you can probably say if they have sleep apnea, it's probably not severe. So we have to look at our patients and listen to. Everyone does not need to go for a sleep study, depending on your clinical sort of interaction with the patient. So I'm almost done. So this is the journey. This is going to be over 10 years to see multiple doctors, multiple psychologists, multiple people. So this is what we got to break. This is what we're here for today, right? We have to complete this journey much earlier, or start the journey earlier and break it earlier, so we can help our patients at an earlier stage to prevent complications and comorbidities and the vicious spiral cycle that we're seeing because of poor awareness and detection. I wanted to end off with, I have a couple more slides. This is a quote that I'm going to read out, which I always put in my slides. And like I said, the patient is the most important. This was Brigitte back in the late 1800s of the Italian actor Ghirlandaio, stating that, quote, "Unfortunately, he could not speak clearly on account of the excessive size of his tongue. The rest of the face had more than the appearance of an ape than a man." This is a quote, by the way. "It was lengthened with very marked prognathism, okay, prominent chin, flattened and indented laterally, as if the cheeks had been elevated by a blow from the hatchet of each side," unquote. These are some take-home points. So it's less common in the elderly, but we're seeing more of it because people are living longer. There's the diagnosis. This is a diagnosis which is often delayed, which we have to break. And there's a lot of overlapping signs and symptoms, right? Whether you're less younger or much younger. And we do know that in elderly, there is increased mortality because they already have a lot of these baseline conditions like diabetes and so on. And the diagnosis is made in the same way with a simple blood test called IGF-1. And we do have effective medical and surgical therapies as we do for younger people. So we have to treat patients for the most part very similarly, and surgical therapy is still very, very important. And treat their diabetes also. Don't forget about these other things. And we have to monitor them and work as a team. This is not in silo. We have to work as a team. Overall, the approach, more or less, with some nuances, is the same as in younger people, as in less younger people. I just wanted to end off by thanking my colleagues. And first of all, I wanted to thank my patients who are here today and my patients in general, because I've learned a lot from them over the last few years. And Dr. Izat, of course, my mentor, who taught me what I know today. Again, once again, if I said anything wrong today, send an email to him that he was wrong. Of course, my family, of course, because without support from family, you can't do any of this work. And most importantly, my patients who I've learned so much from. And we need more Diana. We need more Dianas. So if there's, we need more Dianas. Thank you very much.